So there are really two big unmet needs for the patients that we currently treat for graft-versus-host disease. The first is that there are some patients who don't respond to standard treatment with steroids, so they need to have more intensive treatment at the beginning of their therapy so that we're not waiting to see whether they don't respond and then have to further immunosuppress them. So that's the first unmet need. The second unmet need is that, in fact, most of the patients who are treated with for graft-versus-host disease wind up being treated with high-dose systemic steroids. And at least half of those patients don't need high-dose systemic steroids. It's just that we can't tell at the beginning of their treatment which ones will need it and which ones won't need it. So we'd really like to be able to separate those patients out into high-risk patients and low-risk patients and give them the appropriate therapy that they need right from the very beginning. So today we heard in the plenary session that if one uses post-transplant cyclophosphamide for 2 doses on days 3 and 4 right after the infusion of the graft, that this kind of GvHD prophylaxis actually gives us lower rates of acute GvHD without harming the important graft versus leukemia effect, so that there's less toxicity, but we have the same efficacy. And this is probably going to change the standard of care for many patients who have GvHD prophylaxis, so that centers across the world are now going to start using this kind of post-transplant cyclophosphamide as an important GvHD prophylactic therapy. This morning we heard a very interesting presentation about the first validated response biomarker for acute GvHD. This is the magic algorithm probability, or MAP, which combines the concentrations of 2 serum proteins, ST2 and REG3 alpha, into a single probability. When the MAP is measured at the onset of treatment and then after treatment, the change in the MAP actually correlates with long-term non-relapse mortality. So this is now measuring a response to treatment, and it clearly means that you can use this biomarker, or this combination of biomarkers, as a sort to guide therapy, and it is very likely to help change the standard of care. So I think that there are 2 areas that we're starting to hear about. The first is that patients who get into trouble usually have gastrointestinal graft-versus-host disease. So there are selective treatments that can help inhibit GI GvHD. For example, the use of monoclonal antibodies that stop the trafficking of T cells to the GI tract. I can think of 2 antibodies such as natalizumab or vedolizumab, and these are now currently in clinical trials that are likely to be useful. The second treatment that I think is going to be very useful is we're starting to see monotherapy that is non-steroid based. So for example, itacitinib, which is a JAK1 inhibitor, is now being tested for patients with low-risk GvHD without the use of steroids. So if we can get away from steroids that have so many long-term complications, primarily infections, but bone weakness and diabetes and myopathy, this would be a huge advance. And those clinical trials are just now starting, and we'll be hearing more about that in the next couple of years. So one of the areas that is really very important is to consider the age and condition of the individual being treated for graft-versus-host disease. A 68-year-old man who's had a long-term course of immunosuppression prior to transplant is much more likely to have complications of steroid therapy than an 18-year-old man who had a very short course of immunosuppression prior to transplant. So we're beginning to understand more about those pre-transplant characteristics that will determine which patients are going to be more resilient or more robust, and which patients are less resilient and therefore need gentler treatment. So I believe that we are going to see treatment changing in two directions, both gentler treatment for the patients at low risk who don't need it, as well as more aggressive treatment for the patients who do need it, particularly based on risk assessments that might include biomarkers at the onset of therapy.